But it's certainly the case that the Bangladesh story gives one a lot of reason for asking for more. Because, you know, if you're in a state where nothing is happening, very difficult to say, now we go to universal health care. But if you're in a state where, by and large, the performances have indicated considerable enhancement of the health conditions, then you can actually see how you can make it move much further ahead. And one of the things to recognize here, which is quite interesting, is that, of course, in many of the major criteria of human development, and particularly in the health field, Bangladesh has overtaken India in general, on an average. And yet that story is somewhat misleading, because there are a number of states where that's not the case. I mean, a whole cluster of countries, states like Kerala, Tamil Nadu, and so on, remain well ahead of Bangladesh. Even West Bengal, actually in some respects slightly ahead, and in other respects not so. And then there are some states which are comprehensively behind Bangladesh, making the average what it is. So it's a complex story, and there's something to learn from why is it that certain things are achieved in the neighboring large country, namely India, and why in some other states in the same country it's not achieved. I think there are two ways of thinking about this. One is to go country by country, and I think to some extent it came, and I think the health minister was kindly mentioning that if America has not been able to achieve it, Europe has not been able to achieve it, and so on. I think that's the right question to ask, who has been able to achieve it. I'm not sure that I entirely agree with the answer, because I think Europe has achieved it much more than America has, and it's interesting to ask why that is the case. So I think if you look at, let me begin by this country by country thing, and then I'll go issue by issue thing. If you take country by country, I think US, there has been a real failure to understand that there is a need for universal health care, which is a right. For some, you know, it wasn't a constitutional right at the time of the amendments of the late 18th century. And indeed, as it happened, the first time it was asserted, I think I'm right in thinking, was in the Universal Declaration of Human Rights in 1946, I guess. And even though that was led by an American woman, namely Eleanor Roosevelt, it didn't really have a ripple so much on that. It's amazing for a country which is so rich, how little bump you get from people by saying, how come you could live in a country where some people simply don't have the means of getting medical treatment, when that should be, for a country of this level of richness, very easy to achieve. You will get that as a kind of bump in Europe, and what is interesting, that bump came in Europe fairly early. The big change, of course, was at the same time as the Universal Declaration of Human Rights, namely the late 40s, when in fact it ended up having the National Health Service in Britain and so on. Now, if you contrast the US with Europe, there is a real awareness that everyone has to have a basic health care coverage. That's true of Canada too. But there is a big difference, which is again what while thinking about. In Canada, it's pretty difficult actually to have private health care if you want to have it. That is, on one side, public health care is available to all. On the other hand, you can take insurance for private health care for very specified, actually exactly three things basically: prescription medicine, dental and optical services, and accommodation and beds. So given that, the basic things like surgery and so on, you cannot get, again, universal, you cannot get private health care in that system. You can't even have an insurance system dealing with that. In fact, I say that in the New York Review, and some people immediately protested, but it turned out that, in fact, that is exactly the case. And indeed, there has been a fair amount of discussion on that, happily as it happened, in the American Journal, the JAMA Journal, Journal of American Medical Association. So I think that's a problem here, and I would like to address it, and I might as well do it now. It seems to me that when you're trying to maximize healthcare, it's one thing to say that everyone must have entitlement to healthcare, quite another thing to say that you cannot spend your money on healthcare. You can spend it on a yacht, you can take a holiday to Acapulco, but you cannot have a scan. I think that seems to me no theory. I mean, I'm you know, like all humane people believe that human freedom is quite important, and I don't see why freedom would stop suddenly there and while it applies elsewhere. So I think the thing, the model to look at, therefore, is not Canada, not USA, and to a great extent the model might be Europe, which does permit it. Now there are quite a variety of subjects, and if Ronak and I and others were to sit down for a while, we can distinguish between to sit in France and England and Germany and Italy and so on. And it's also some of the least suspecting countries have improved their healthcare very, very much indeed in the public field, including Italy. The other thing to recognize is that the basic model that first began in Britain with the National Health Service had one very big feature, namely that delivery of healthcare was not by giving you cash, but providing you actually the service. So that is a big difference, and that's not the pattern of the new countries to which I see some references as I look at this document, namely, Thailand and I was told Rwanda, but South Africa and so on, because basically they are a question of giving you money. And of course that is the Obama health service is exactly that. It's private insurance, competition between them, establishing rules on them so that they cannot exclude those who are challenged because they already have a health condition. I would have not had a health insurance of that kind, and all since the age of 18 I had cancer, and that would have ruled me out from any kind of general health coverage. And there are a lot of other people like me, and in the end I didn't prove to be, I think, since I'm 78 now, such a bad money-losing bet for an insurance company, but at that time I certainly would not have got it, and of course I won't get it now either. But the basic fact is that insurances have a problem which we have to deal with. So let me move away from the country-by-country thing to issue-by-issue thing. So one question is, let's begin with that, insurance. What's wrong with insurance? Now on this, I think the classic paper was written by a very established, very mainstream economist, who can't be more mainstream than that. Actually by two mainstream economists, and none of them could you beat in terms of mainstreamness. One was Kenneth Arrow in the 1971 or 73, I can't remember now, in the American Economic Review, about why asymmetric information is a big problem there. There are two things: that the doctors know something about your health condition, if they really do examine you, which you don't. So that in that situation, it's very difficult for you to have a demand and supply, perfect information in equilibrium. It's not like buying a toothpaste or toothbrush which you have tried out and then you know which one you like and which one seems to me to be not likable at all and so on.